All right. We're letting people in?
Mm-hmm.
Okay. Oh. All right. Okay. All right, just waiting for a few more audios to connect, and we will begin. All right, we're just waiting another minute. I want the secretary's audio to connect before we start. Oh, there we go. Okay, I think everybody's on. Thank you, everyone. Welcome to the Health and Social Services Subcommittee of Appropriations. We have one budget today. And just for everyone's notice, we are getting very close to the end. We have another budget hearing tomorrow, and then Medicaid on Monday, and then June, correct me if I'm wrong, but I think that's it.
Yeah.
And then we will be done and ready to move forward with decisions, which is always a fun part of our session. So today we are hearing the Developmental Disabilities Association but administration budget of the Department of Health. As always, we start with our analyst report, then we go to the department, and then we go to a witness list. Today, I believe we have 4 people signed up to testify. Just as a quick reminder to everyone, this is being live streamed. Everything said or done or typed into the chat box is going to be streamed out to the public as well as available for public information requests. So with that, let us begin. We'll start with the analyst report and Morgan. So Morgan, take it away.
Thank you. Bear with me while I share my screen. Okay, hopefully you can see that. So I'll be presenting the operating analysis for the Developmental Disabilities Administration today. And here on page 1, you can see the fiscal 23 budget for DDA. It increases by $107.8 million or 7.1% to $1.63 billion in fiscal 23. Most of this increase occurs in the community services program. There is $30.2 million for the expansion of waiver services, $57.4 million for the mandated 4% provider rate increase, and the first supplemental budget of 23 added $85 million related to the 10% enhanced match on home and community-based services as authorized in the American Rescue Plan. So that encompasses most of this increase. Jumping to page 5, you'll see a graph identifying the individuals served across all DDA waivers. One of DDA's primary goals is to increase the number of eligible individuals receiving community-based services and enrolled in a home and community-based service waiver. They hope to get 0.3 percentage points over the fiscal year enrolled into these waiver programs. And in fiscal 21, DDA saw 97.7% of individuals receiving community services enrolled in the DDA waivers, which is an increase from fiscal 2020, where they saw 93.5%. So they definitely met their goal in fiscal 21. On page 6, we'll move to Exhibit 2, which outlines the availability of DDA waiver slots. When an individual fills a slot, it's considered used. This count is maintained throughout the fiscal year to date and includes individuals who have since left the program. So if an individual is in a slot and then moves out of state or otherwise leaves, the slot is still considered used. However, if the numbers that are in the active column, those show slots that are currently filled by an individual right now. You'll notice that the chart shows that Community Pathways has the most total slots. This waiver supports both children and adults in receiving meaningful day support and residential services. So it provides a range of services. DLS has asked MDH to comment on the efforts the department is making to increase utilization of the available slots, because this chart shows that there is a number of authorized waiver slots that aren't used. We're also asking MDH to comment on the impact of unfilled slots on their ability to use the 10% enhanced match to expand waiver slots and provide an update cost estimate per waiver program because these costs I don't think are accurate currently. On page 7, you'll notice Exhibit 3 shows the point in time community service waiting list counts. DDA tracks more than 3,700 individuals who meet the statutory requirement of having a developmental disability, which is what is shown in Exhibit 3. These numbers are only those who meet the statutory requirements. And you'll note that in the note, it talks about the groups that are in the supports only category are not included in the count. They're broken into priority categories. So crisis resolution is the highest risk. Those individuals are typically at risk of harm or homelessness. The lowest risk is current requests, and those individuals typically have no risk of harm or homelessness. In recent fiscal years, the number of individuals on the waiting list has been decreasing. Previously, DDA reported that the expansion of funding has allowed for more new placements for individuals, specifically individuals in the crisis resolution category and those transitioning youth who are aging out of the educational system, the foster care system, or the Maryland State Department of Education's autism waiver. A brief note about transitioning youth. So transitioning youth qualify for a reserved category on the wait list to account for their applications for DDA funded services upon aging out of whatever program they're previously in. Between graduation and being enrolled in DDA services, these qualifying transitioning youth are eligible for meaningful day and employment services through the governor's Transitioning Youth Initiative. And during the pandemic, these transitioning youth, some of them were unable to complete the waiver enrollment application process, which impacted their ability to receive these meaningful day and employment services throughout their transition. Through the state of emergency, transitioning youth who would have otherwise aged out of their program and been disenrolled from services completely are able to submit the DDA waiver as late as June 22 to be considered for DDA funding. And this is provided under the Emergency Preparedness and Response Appendix, also known as Appendix X or Appendix K, which I'll talk about later on in the presentation. DLS asks MDH to comment on the current status of the wait list, including how many individuals are in each of these priority categories. Page 9 discusses the waiting list equity fund balance over the last 5 fiscal years. Currently, statute dictates how the fund is used, and it prevents funds from being used for emergency placements and transitioning youth, as well as restricts the funds for the first year of an individual's placement within the community. So the balance of the fund has continued to grow because of these restrictions and due to low spending. Between fiscal 2020 and 2021, the fund grew by approximately 1.1 million to 11.4 million. And we're asking MDH to comment on any progress in considering options to adjust statute to expand the allowable uses for the fund, primarily to reduce the growing balance. I'm going to briefly talk about fiscal 22. So in fiscal 22, the Families First Coronavirus Response Act provided an enhanced federal medical assistance percentage, also known as FMAP, of 6.2 percentage points on qualifying expenses made during the nationally declared health emergency during this pandemic. This applies to eligible spending under DDA's 3 Medicaid waiver programs beginning January 1st, 2020. The fiscal 22 budget, as enacted, reduced general funds spending in DDA by 37.5 million in general funds in anticipation of the receipt of the FMAP for the first 2 quarters of the fiscal year. The fiscal 23 budget adds 20 million of general fund savings as a reversion due to the extension of the public health emergency for the 3rd quarter. And then the first supplemental budget of 23 included a proposed deficiency to recognize 21.5 million in general fund savings. And so there was an equivalent federal fund appropriation for that amount. DLS is under the impression that the associated federal funds for the first 3 quarters have not been added to the fiscal 22 budget for DDA, despite occurring in other areas of MDH. So we're asking MDH to comment on why the additional federal funds from the first 3 quarters have not been added to the budget. There is also an enhanced federal match for home and community-based services. The American Rescue Plan increased the match for qualifying Medicaid home and community-based service spending by 10 percentage points, specifically from April 1st, 2021 to March 31st, 2022. The value of this 10% enhanced match has to be invested in home and community-based services by March 31st, 2024. The fiscal 22 budget saw $85 million added by budget amendment for DDA reinvestments. And the supplemental budget, the first supplemental budget of 2023 provided $85 million in federal funds also for this purpose. There's language in the fiscal 22 budget bill that requires DDA to spend at least 75% of the federal funds attained from this match for a one-time Medicaid home and community-based services rate increase for providers. And the remaining 25% must be utilized for grants to providers and administrative expenses. MDH reported that these funds will be used for a temporary rate increase to 5.5%. It was retroactive from April 1st, 2021, and it's going to continue through March 2024. The reported total cost of the rate increase is estimated at $221 million. And MDH reported that they intend to use another $60 million for grants to providers and $24 million for administrative purposes. DLS is asking MDH to provide an update to the committees on the planned expenditures by fiscal year for rate increases and other enhancements. Exhibit 5 on page 11 provides an overview of agency spending. The fiscal 23 allowance totals $1.63 billion, and 99% of that budget is dedicated to provider payments within the community services program specifically. There's another 1% being used for program direction, and that's $11 million. Within the 99%, you'll notice that residential services makes up the largest chunk at 48%, or $777 million. DDA estimates the average annual cost per residential client at $135,480 in fiscal 22. This is a decrease from the most recent actual in 21 of $135,971, so a small decrease. The comparison, or for comparison purposes, day programs, which is this 13% chunk, serves more clients annually, but the average annual cost per individual is much lower at $18,670. Other operating expenses, the other operating expenses chunk of the pie chart covers the regional offices, which oversees services provided, with funding allocated at $28.3 million. This overview also includes this chunk for the 10% enhanced match for the home and community-based services as discussed earlier. Exhibit 6 on page 12 highlights the proposed budget changes for DDA. The fiscal 23 allowance increases by $107.6 million between the 22 working appropriation and the 23 allowance after accounting for both the proposed efficiency appropriations and the supplemental budget, the first supplemental budget from 23. The majority of this increase, as I said previously, is in community services, including the $20 million resulting from the targeted reversion in fiscal 22. DDA also sees $87.8 million to cover the expansion of waiver services and new placements and the mandated 4% provider rate increase. Page 14 discusses personnel changes. So DDA saw a decrease of 2.5 regular positions between the 22 working appropriation and the 23 allowance. 2 of those positions were transferred to the chief medical examiner's office, and there was a part-time position transferred to the Board of Nursing. The 23 allowance also includes a net decline of 11.17 contractual full-time equivalents compared to the 23 working appropriation. And this decrease is primarily due to adjustments between community, residential, and day services to align more closely with the prior year's actual FTE counts. There's also 20.5 vacancies as of December 31st, 2021. 14.5 of those were within the community services regional offices, with the majority of those being service officers, secretaries, and administrative positions. Page 15 starts a discussion about COVID-19. So you'll see here on Exhibit 7, it highlights the positive rates across DDA service regions. The Deputy Secretary of DDA provides monthly webinars with information on COVID-19 related updates, including vaccination and positivity rates periodically. On October 29th, 2021, the webinar cited that of the 17,764 DD community members, 2,362 of those individuals had tested positive. And as of that webinar, the community had seen 114 deaths. It's important to note that these figures predate the Omicron variant, so we don't have a current update for those numbers. Page 16 highlights the breakdown of vaccination status across DDA participants in Exhibit 8. DDA reported that as of the October 29th webinar, there were 15,896 DDA participants who had gotten their vaccine. That was about 92%. As of January 28th, 2022, the agency reported a little over 4,300 participants had also received their booster shots. DLS was provided the recent vaccination data after the finalization of the analysis. So the analysis still includes bold language asking MDH to comment on vaccination rates, plans to encourage the booster shot, and impacts of the Omicron surge across DDA. Issue 2 discusses the report on community services utilization data collecting and the spending forecasts. This was included in language in the fiscal 22 budget bill, which withheld $1 million of general funds of administrative funding in DDA pending the submission of this report. This report was due on November 1st, 2021, and it was received January 13th, 2022. This report is important primarily because DDA is moving from a prospective payment model to a fee-for-service reimbursement model. This transition includes moving service authorization and billing functionalities from the legacy Provider Consumer Information Systems 2, also known as PCIS2 system, to the state's existing long-term services and support system, also known as LTSS, which is utilized by other Medicaid programs across the state. During this change, DDA will be implementing new community services and provider rates. And in Exhibit 9, you'll start to see some of this data that was provided by MDH. This is a summary of the number of individuals and providers billing through LTSS prior to fiscal 2022 and year to date in fiscal 2022. The early adopter group pilot, which transitioned in July 1 and on October 1 of 2021, transitioned all of their individuals from those providers to LTSS. So they give the most updated real expectation for what this transition is going to look like. The other 3 groups, DDA pilot, personal supports, and supported living, those providers only chose a handful of individuals to transition. So it wasn't their entirety of the individuals that they service. In the report, MDH indicated that the monthly reports on utilization by service type would be submitted to DLS no later than the 15th of each month, with data from the prior month included in the report. This timeline did not include a start date, and as of the writing of the analysis, DLS had not received an initial report. MDH did provide some details in the report, specifically from July 1, 2019 to October 31, 2021. Exhibit 10 highlights that data, and it is showing you the number of claims by service type for DDA-funded services billed through the LTSS system. You'll notice that targeted case management accounts for the vast majority of these claims, and that's because these services transitioned the earliest in comparison to the other services. And the other category accounts for the least number of claims, totaling 9,184, and that's less than 1% of all claims billed through this LTSS system in this time period. To compare expenditures under LTSS to the prior reimbursement model, MDH provided claims paid to DDA providers by service between December 2019 to December 2020, as shown in Exhibit 11. So what you're seeing here is the amount of money that was charged in LTSS versus PCIS2 and the percentage change in what that cost was. So you'll see that the pilot providers received roughly 62.2% more for claims using the fee-for-service rates in LTSS as compared to the PCIS2 model. This 62% may not be reflective of actual costs of the new payment system when all the providers and clients are enrolled. For illustrative purposes, a 62% increase in provider payment would require an additional $850 million of annual expenditures by DDA, including $463.5 million of state funds. The fiscal 23 allowance does not provide funds to begin an implementation of such a transition. The department should discuss over what time frame it intends to implement the new rates and how it will do so in a manner that is affordable to the state. MDH should also discuss how it will balance phasing in the new payment system while continuing to expand the number of people served during the rollout. Exhibit 12 on page 20 provides the timeline, the rate setting process provided by MDH. At the time of submission, MDH indicated that they're continuing to work with advocates and an actuarial firm to finalize the rates for 23 and plan to be able to forecast general fund spending following the fiscal impact analysis completion. MDH should comment on the status of the finalized rates, as well as when the general fund forecast using these rates will be available. In addition to all of the information that I've previously outlined from this report, MDH provided a description of the data that's available through the LTSS system and outlined ways in which LTSS provides the electronic exchange of data for DDA users. It's unclear if the providers can utilize the ability to exchange data currently, or if these abilities are built but not distributed. So we're asking MDH to comment on whether providers can utilize the data exchange features currently, and if not, when these features will be available for their use. DLS recommends restricting funds in the fiscal 23 budget pending submission of a report on the continuing transition of the LTSS system. DLS also recommends committee narrative requesting the submission of the monthly utilization report that they said they could provide on the 15th of the month. Otherwise, DLS recommends the release of the $1 million in general funds restricted from the 22 budget pending the submission of the report, and will process a letter to this effect if no objections are raised by the committees today and tomorrow. I do want to briefly provide an update on Appendix K. So Exhibit 13 on page 24 shows Appendix K provisions. So Appendix K for DDA's Medicaid waiver program has allowed for flexibility with service requirements and financial support to providers during the pandemic. Effective January 21, 2021, Appendix K was extended to 6 months after the nationally declared public emergency, meaning currently Appendix K provisions are extended to October 22 without any additional extensions of the public health emergency. Chapters 70 and 71 of 2021, which were effective July 1st, 2021, allow some modifications under Appendix K to extend indefinitely, including the provisions that involve remote or virtual services. For your leisurely reading, Exhibit 13 highlights all of the provisions under Appendix K that have a set date for termination and the ones that are extended indefinitely to our knowledge. Page 25 starts to discuss the update of the federal disallowance. To give you a brief overview, in June 2015, the Office of the Inspector General at HHS released an audit report that detailed overbilling of federal funds totaling $34.2 million, specifically for residential habilitation add-on services. The report recommended that the state refund this money to the federal government, but MDH did not concur with the recommendation and instead issued a request for reconsideration letter to begin the appeals process. They decided to retain the funds and pay any accrued interest if the appeal is rejected. According to the Office of Legislative Audit's statewide review of budget closeout transactions for fiscal year 2021, there has not been any additional action or correspondence regarding the final determination on the request for reconsideration that was sent in August 2018. Jumping back to page 22, I just want to walk through the recommended actions one more time. So action 1 would restrict $1 million from DDA until MDH submits the report each quarter to the budget committees regarding the ongoing transition to the fee-for-services reimbursement system. This recommendation is slightly altered from last year's recommendation, but uses most of the same language. The slight changes are just to provide a more specific request for data to try to really hone in on what we wanted. As each report is provided, there's the chance to release $250,000 for each report. Action 2, pardon my scrolling. Action 2 is language from last year. Restricting appropriations provided for community services to only be used for those purposes and may not be transferred out of community services to other areas in the department. This is annual language that we would like to continue adding into the analysis to address previously reported increasing net general fund transfers out of community services to elsewhere in the department. And the last recommendation you'll see here is on the community services utilization data. So Action 3 recommends adopting narrative to require MDH to submit the LTSS data they indicated they'd be able to provide on the 15th of each month in the JCR report that I discussed earlier. This action gives a specific date to the department on when they should begin providing this data, as the committees had not received an initial report as of the time of the writing of the analysis. With that, that concludes my presentation, and I'm happy to answer any questions that you have at this point.
Wonderful. Thank you, Morgan. Really appreciate the in-depth analysis. Are there any questions for the analyst? Seeing none, I have one quick question. Morgan, you did talk a lot about the rollout of the LTSS system, which is very helpful and informative. As far as the overall timeline for LTSS, the full rollout, where are we on that? You know, how much longer do we have to go before it's fully rolled out, before everyone's on it? You know, what was the original plan and how far off are we from that?
Let me show you the timeline and I can walk through it with you.
Okay,
this is the most updated timeline that we have for this process. And so you'll see that as of March 2021, which is the most recent update that we have, they had to redo the rate structure after talking with Max a little bit, and to try to address the concerns with the geographical differential rate compared to the rest of the state. So that's where they're at right now. You'll see that in May 2021, they engaged with Optimist to work on the actuarial review. I don't have an update on that actuarial review or where it's at in the process. And then in July and October of 2021, that was when they got the 5 providers into LTSS with all of their individuals that they're providing to. I don't have an update as to when more individuals will be pulled into that system, but I think that the department might be able to give you a better understanding of what that timeline now looks like.
so you haven't gotten a real update, frankly, in almost a year.
That would be accurate.
All right. Thank you. All right. Seeing no other questions, let's move to the department. Secretary Schrader, please feel free to introduce whoever you have with you and provide your response.
Thank you, Mr. Chairman and members of the committee. For the record, my name is Dennis Schrader, Secretary of Health. Our Deputy Secretary, Bernie Simon, sends his regrets. He had a family medical emergency and couldn't be with us today. Assistant Secretary Yee will provide the responses to the analyst questions. We also have our CFO, Emily Brandenburg, and Rhonda Workman and Robert White from DDA, as well as Nick Napolitano to answer questions. So I will say that, and Assistant Secretary Yee will give more information. We have actually made phenomenal progress working with the DDE Coalition on the LTSS and rate setting process. I know we've got a report that's somewhere in the pipeline, but since the summer, there's been significant progress. We can talk more about that in the question and answer period. So, Mr. Yee, if you could give the responses to the analyst questions.
Thank you, Mr. Secretary. Good afternoon, Mr. Chairman, members of the subcommittee. Webster Yee, Assistant Secretary, Maryland Department of Health. We have submitted a more detailed written response for the committee's reading pleasure, so I'll just briefly summarize our responses. To the first prompt about what steps the department's taken to increase utilization of the available slots, the first overall comment is we're using, in partnership with the Maryland Department of Aging, their Maryland Access Point service. And this is a service where the 20 Maryland Access Point agencies serve as a single entry point / no round door for individuals and citizens to plan, identify, connect, and assist with accessing both private and public resources for long-term services and supports. And this applies to individuals with developmental disabilities, anybody looking for Medicaid, long-term services, planning, that sort of thing. So it's a one-stop shop to a large degree. In addition, we are specifically, with respect to the Medicaid side of the world, we've included reserved waiver capacity. And in our response, we've given out the specific examples as well as the specific circumstances by which slots are reserved. I should note that of the 3 waivers, Community Pathways waiver has about 775 slots, Community Supports has 478 slots annually, and the Family Supports waiver has 28 slots. And again, our written response details out very specific details there. To the second prompt about the current status of the wait list, the most recent wait list count as of February 16th is 7 in crisis resolution, 176 in crisis prevention, and there's about 3,500 in the current request category for a total of 3,728. The total number of individuals taken off of the wait list in fiscal years 20, 21, and 22 are in a table. In 2020, the total was at 1,735. In 2021, it's 1,267, and then so far year to date, it's 511. To the third prompt about progress in considering options to adjust the statute to expand allowable uses of the waitlist equity fund. The department has statutory language drafted that will achieve this goal and is always willing to engage in dialogue with any interested legislator or stakeholder on the fund. To the next question about why the additional federal funds from the first 3 quarters have not been added to the budget, we are currently working on the second quarter projections and developing a federal funds efficiency estimate. As soon as that's ready, we'll have the appropriate discussions with our next steps. With respect to the planned expenditure by fiscal year for rate increases and other enhancements, again, we thank Ms. Smith and DLS for their very insightful DLS analysis. What we've said previously and what we're saying here with DDA specifically is we use 75% of the reinvestment funds from ARPA on a 5.5% rate increase. The rate increase was retroactive to April 1st, 2021, and as previously discussed, we intend to use ARPA funds as long as they're available, which is currently estimated to go through early calendar year 2024. We should note, with respect to the $60 million in provider grants, that late on Monday afternoon, we received new information from the U.S. Centers for Medicaid and Medicare Services, where CMS has determined that these grant funds are not eligible for a federal match. And as a result, we will do some recalculations and have further discussions with both CMS and stakeholders. Our latest spending plan is posted on our website, and in our written testimony, there's a link to that, and we will update the spending plans as things keep on going. With the next prompt about vaccination rates, we are pleased to report that 80% of the individuals known to DDA have been vaccinated, or about 16,000 of the 20,000 participants. As of Monday, about 5,200 people have received their booster shots. We're sad to say, unfortunately, since March 2020, that about 3,250 cases of COVID have been reported for individuals receiving DD services. And we are very sad to report that of that, about 131 deaths have occurred, including 14 direct support staff. This is information based on self-reported surveys from the 278 providers responding to our surveys. We have encouraged all DD providers to ensure that their staff have the opportunity to be vaccinated, and we have made available to the DD providers. Any DD provider can request a mobile vaccine clinic through our call center or through our web link, which is governor.maryland.gov, GoVax Mobile, or 1-855-Maryland-GoVax. In addition, through a departmental order, we have required that all providers and operators of DD group homes offer to their residents the opportunity to receive an additional dose or booster shot of COVID-19 vaccine. And then, of course, lastly, all Marylanders, including individuals with developmental disabilities, are encouraged to get a booster shot to participate in the current Vax Cash 2.0 promotion that goes through early May. To the next question, or excuse me, prompt about the fiscal 2023 allowance and the implementation of the LTSS transition. The Governor's Supplemental Budget number 1, item 27, provides for $85 million in federal funds for the home and community-based services rate increase and the transition to the LTSS Maryland DDA module. We've also indicated our latest timeline, which we have discussed in the over 27 weekly meetings with the DD Coalition, our intended timeline and transition to the LTSS. Currently, we are in phase 1, the Group A, which is a 6-month expanded voluntary pilot of providers, and then we will move on to phase 2, Group B, a secondary pilot for voluntary interested providers at the beginning of fiscal year 2023 or during the summer. And then in phases 3 and 4, we'll proceed to a network-wide go-live, along with an anticipated final go-live towards the end of the fourth quarter calendar year 2022 as tweaks and changes are required. Then to the next prompt about the status of the finalized rates. Currently, providers are working on the fiscal impact analysis tool to determine the impact of the new rates on their revenue. Once they've completed this tool, we will work with the Hilltop Institute at UMBC to analyze this information, validate it, and we will then move on to next steps about rates and load the rates hopefully by April of this year. To the next question about whether providers can utilize the data exchange features. Currently, we'll simply state that we do not recommend, or we do not agree with the withholding of $1 million. We do have regular meetings with stakeholders in DD provider community, as well as the Developmental Disabilities Coalition. We're perfectly happy to work with DOS and their request for information. And with that, Mr. Chairman, we'll turn it over for questions.
Thank you for that. So I think we can begin, Mr. Secretary, with that update, a little more detail about LTSS and any progress that has been made since the last time our analysts got any real information.
Right. Let me start by saying last summer we started a very detailed process with the DD Coalition, and I think as Secretary Yee mentioned, we've had about 20 meetings with them to do two things. One is to deal with the Appendix K transition, which had significant effect on the rates, and we're projecting what those rates will be through calendar year 24, and to work with them on the process of transition to LTSS. As the analyst pointed out, a significant number of providers have already transitioned, but we have about 220 or 230 to go. And in that, some of them have already been in LTSS working with the electronic visit and verification system, so are being paid. But have not transitioned all of their business to LTSS. The other thing we've done is we've worked with the providers to create an annual rate setting process. So we are now in the spring going to be loading the rates in the spring. There will be, we're working with the volunteers who want to go forward. We had the 5 early adopters, and we have a series of volunteers, and we are going through with them to make absolutely sure they're ready. And then sometime this spring, we will start them down that road. We want to make absolutely sure the providers that go on to LTSS are successful. So we're spending a lot of time. One of the feedback messages we got back last summer, which we've been working on diligently with the DD Coalition, is there was so much change because of LTSS and the rate setting and COVID that they needed more hands-on. And so we actually reorganized DDA and created a change group that's been very hands-on, working with the providers and the DD Coalition, and that has been very successful. We're very grateful to the Coalition for their leadership in helping us with this. Once we get through this spring with the next round of providers, we're already teeing up the second round that will go probably in through the summer and the fall. And we're being very careful not to force people to go onto the system until they're ready. And so we don't have a firm end date because we want to allow the providers to come aboard as they feel comfortable and as we assess their readiness. I think this spring's transition is really critical because that's the first bolus of providers, and as I said, we want to make sure they're successful, but we expect after that we will gain momentum through the rest of the year, and as we're more confident and the providers are more confident, we'll get more aggressive in setting an end date to the final transition. So a lot more to come. I believe we've submitted a report. Secretary Yee, when was that submitted? January 13th. There is a report in the pipeline, and it should lay out a lot of this information. But this calendar year is going to be really critical in terms of this final transition.
All right, thank you, Ms. Secretary Schrader. Yes, this calendar, I mean, I think most of the calendar years have been critical because I've been hearing about LTSS now for, I think, almost as long as I've been hearing about MD Think, and both of them have been dragging on over, almost the entirety of the Hogan administration. So it would be nice if we can bring it to an end and actually have working systems. I have a couple
if I could, Mr. Chairman, sure. LTSS has been a Medicaid-wide home and community-based services platform that has been around since 2013 and 14, and will be expanded to many services over time. This is just the latest one. There will be others. So it's a platform that these applications sit on as we do one application or one population after another. This is the latest one.
Sounds good. I have a couple other questions, but I want to give my subcommittee an opportunity to ask other things before we get back to me. So I believe Delegate Valentino Smith, did you have your hand up? Yep. Please go ahead.
So thank you, Mr. Chairman. Thank you, Secretary Schrader and Deputy Secretary. Just two questions. One, in terms of the wait lists, are you able to break it down for us with respect to the demographics of the people served so that we can make sure that we're not having any kind of unintended consequences with certain populations not being proportionately represented on the wait lists?
I believe we can. And Rhonda, did you want to add anything to that?
Yes, this is Rhonda Workman from DDA, and we can definitely pull out the demographics that we have available within our system and share that.
So we can look at like whether or not our Hispanic community is represented and all of the different communities that are represented.
Based on the data elements that we're collecting, yes.
Thank you. That would be helpful. The second question I had was the Chair Resnick and I spent a lot of time in the interim serving on the summer work group on patient choice and control of services, the self-directed advocacy work group, many hours. It was really a good work group in terms of the department. I know Bernie's not here and he might be the one that's got all the answers. But where we really heard and took the time during the interim to hear the changes that the department could make that would still be consistent with federal law, that the advocates thought actually provide a higher quality product to them. So I'm just wondering, if not providing the answer now, they issued a report, it's 10 pages, and on each page was a topic with a recommendation for the department. If you guys have, responded to that report or you're starting to make changes pursuant to all that work that was done.
Yeah, I'll ask Rhonda if she has anything to add, but I'll say two things. One, where we are working with the policy committees on that report. And two, if Bernie were here, his number one priority when he started here in Maryland was to expand the SDAN, and it has grown dramatically over the last 5 or 6 years. But so we're glad to bring more people into self-directed. But did you have anything to add, Rhonda? You might want to move over so
exactly.
the Vice Chair can see you.
Hi, and thank you for the opportunity to talk about self-direction. As the Secretary said, we're very excited about self-direction, and it is one of our priority focus areas. As we shared with the committee the last day that it met in December, we looked at the initial recommendations that were shared with us and categorized those in terms of actions that we could move forward with and other actions that we would need to follow up with CMS or wanted to partner with the Self-Directed Advocacy Network and stakeholders on things such as the training that's recommended, not only for the coordinators of community services, but also for participants and families. So we're working to look forward to actioning specific plan related to that. In addition, as you may know, the Self-Directed Services Act of 2020 bill is going to be here next week. So we've looked at that and at the opportunities there. Some of the recommendations had changed from the December one, but I'm excited about continuing the opportunity to meet with SDAN as we do on a monthly basis with both the Deputy Secretary meets in addition to quarterly meetings with Deputy Secretary Beatty.
Thank you. It's a long answer about us being hopeful that there are meetings and that there are outcomes, but still coming up a little short. I guess we'll watch the other hearing. I know one of the biggest ones was the overnight opportunities that you had to amend the waiver pursuant with federal law, and that seemed to be one of the biggest things that the advocates were concerned about. So not to belabor this, we'll get that final report, but if you've applied to CMS for any of the changes, this has just been months and months and months, it will be helpful for us to know how you're responding to the changes that you did have the flexibility to make. So thank you, Mr. Chairman.
Thank you. All right. Any other questions? Okay, seeing none, I do have a couple I want to follow up on. In the analysis on page 9 under what was it? It's the Morgan, help me out. What was the acronym? I forgot it.
It's the FMAP for fiscal 22.
So under that section, it showed that $79 million of DDA funds are being replaced by federal funds that we're getting from various sources, and which is great. Glad the federal funds are coming. But once those federal funds are gone, the reductions are going to hurt. Is there a plan for replacing that money? Or what's the plan for once the federal money has been spent?
So, Mr. Chairman, this is Webster. This is one of the questions that we're working through still with the budget chairs and also DVM. So this is something that is, I don't think we necessarily have an answer on this date, but we are certainly working through it.
Okay, so we do have, we had the money budgeted. It's a reduction and being replaced with federal money, but we don't have a plan for how we get that money back in.
Well, again, like this goes to the calendar year 2024 question. And again, I think right now it's a little bit premature to speculate as to exactly what the next administration will do in their budget. But again, we're actively working on this issue and we are trying to develop some solutions.
Okay, sounds good. Last question, in terms of the rates being developed, can you clarify for me, once you have new rates, is it correct in my understanding that initially you're only going to fund 86% of them? And if that's the case, what's the plan for getting to the full 100% funding?
Yeah. I'm going to ask Robert White, our financial director for DDA, to comment.
Hello, Mr. Chairman, and thank you for the opportunity to speak here today. And so as far as the first and foremost, one of the things we wanted to do is make sure we got to a rate that was sufficient and one that was foundational and based on data available to us. And so what we've done was modeled out a glide path that shows that, you know, initially we will be funding the rates at 86%. If nothing changes based on the fiscal impact analysis tools that the Secretary spoke of earlier, that the providers are now completing and the Hilltop Institute is now analyzing. We have projected a 3-year glide path to get to a fully funded rate. So we would start at 86% based on conversations that we've had with DBM and based on the 5.5% increase in ARPA funds available through FY24.
Okay, so that raises a couple questions for me. So if we're setting rates, when we're going through a process of setting rates, that process determines what we feel is the appropriate amount of money that we need to pay to providers to do the service that we need to do, that we ask them to do. So if we're saying that the rate is X amount, but we're only going to pay you 86% of what we have actuarially determined you need to be able to provide these rates, are we saying that we are deliberately underfunding the providers and will only fund you after 3-4 years at the appropriate rate, by which time inflation and other factors may have forced that rate to go even higher? Is that essentially the plan?
No. So, you know, when you go in to set rates, you set those rates not based on what the state can afford to fund, but based on the data that you are collecting. And so, and then you get an amount, okay? So hypothetically, let's say that, you know, that fully funded rate based on the rate methodology and the work of the internal and external work groups, then, you know, you would have that number. But then from a budget perspective, you know, the state can only fund so much of that rate. And so what we would do is put a plan in place that would show what a glide path would look like to get to a fully funded rate. Now, in addition to that, at least through FY26, there's a 4% COLA that providers get on an annual basis. And so that COLA would still apply to the rate as far as the cost of living allowance. But it would be kind of not a best practice to base your rates on what the state can afford. You need to base the rates on the actual data that you're receiving, and then figure out what percentage of those rates can be funded based on what the state can afford.
I think we said the same thing. I think we're saying the exact same thing, which is we all acknowledge that the providers need X, but as a state, we are only willing or able to pay them 86% of X. and then we hope to get to X within 4 years. But in addition to that, we're adding a 4% COLA to X every year. So at the end of 4 years, we're still not going to be at 100% because we'll have be 16% over that in COLA. So we are deliberately setting rates that we cannot afford to pay. Is that what we're saying?
Yeah, Mr. Chairman, this is part of the continuing conversation that we are having with both the stakeholders and other state partner agencies. So again, we'll get back to you, sir.
Okay. All right. Thank you. I may be a lawyer, but I'm pretty good at math, so which is why I'm on a budget committee. So I just want to make sure we're all on the same page as to how these rates are being functioned. All right, sounds good. That's it for me. Anybody else have any final questions? Seeing none, thank you to the department. We're going to call witnesses now. We will start with Laura Howell from Max.
Good afternoon, Mr. Chairman and members of the committee. Thanks so much for having us today. I am with the Maryland Association of Community Services. We represent about 120 community providers who provide over 80% of the services funded by DDA. And I want to thank this committee for your longstanding support for people with developmental disabilities. We are here in support of the governor's DDA budget, and on behalf of the DD Coalition, I want to express our deep appreciation to Secretary Schrader for his extensive commitment to the developmental disabilities community and the issues we currently face. And as Mr. Yee said, all of the meetings that we have had since the middle of July. I need to say that I am incredibly proud to represent community providers because they have done work over the last 2 years that no one thought was possible. And yet where we are is not pretty. Our workforce crisis is nothing short of disastrous. Our most recent data from January shows that 1 in 3 providers reported a vacancy rate of direct support staff between 30 and 60%. And most alarming is that almost 1 in 10 had vacancy rates between 50 and 60%. Almost 1 in 10 vacancy rates between 50 and 60%. I have never seen that before. We can't continue like this. And Secretary Schrader and his team have worked very hard to get the federal ARPA funds out to providers as soon as they could, which resulted in a 5.5% rate increase on top of the 4% that was budgeted. And while it is deeply appreciated, it hasn't put a dent in our workforce problems. 2 days ago, Target announced that they are raising their starting wage to $24 an hour in many areas and beefing up their benefits. And we see that across the board. And without a solution, we will not be able to continue to meet people's needs. And to be blunt, staff who are providing care and support for people with developmental disabilities should earn more than people stocking shelves. The 4% rate increase in the minimum wage bill has not come close to keeping our wages above the minimum wage. And it's important to point out that this is especially in light of the fact that that bill in 2019 assumed a 2% increase in inflation annually, not the 6 to 7% we are currently facing. People with developmental disabilities and their community providers need help now, which is why we're urging Governor Hogan to put $35 million in general funds into a supplemental budget to increase rates and speed up the glide path that you heard about to the new rate system. And we hope that you will support this effort. And lastly, I just think it's important to note that the revenue increase referenced by the analyst for the pilot providers, which was a very small group and a very small number of people in the pilot, was based on proposed rates that have since changed. And we maintain concern about the rates for some services, and we've communicated this with the department, particularly meaningful day services, that right now, based on the current version of rates, appear to reflect financial loss for many providers. So I want to thank you again, and I'm happy to take any questions.
Thank you. Like I said, we have 4 people signed up to testify. We're going to go ahead and have all 4 people testify. If anybody in the committee has any questions for any specific individual, we can address them after the fact. Next, we'll move to Matthew Rice from the ARC of Maryland.
Good afternoon, Chairman Resnick, members of the committee. My name is Matthew Rice. I am the Director of Public Policy for the ARC of Maryland, which is the state's largest advocacy organization, which advocates for the rights of people with IDD. We are here in support of the governor's budget for the Developmental Disabilities Administration. And I want to echo what my colleague Laura Howe said about how appreciative we are to the governor and his team from DHMH for the ongoing dialogue with addressing the needs that our community has. The reality is we need the funding for the Developmental Disabilities Administration budget sooner than 3 or 4 years. In addition to the struggles that the provider community is facing, there's a growing constituency, which Delegate Valentino Smith referenced in her earlier question about self-direction, with individuals with disabilities who self-direct their services. This means that we are the employers of record. We hire, train, and recruit our support staff, and if necessary, unfortunately, sometimes we have to let them go. I can tell you, I'm not only coming before you as a policy person, but I'm coming before you as a user of the services. I self-direct my own services. I think what we've seen is that we definitely need more supplemental funding. The rate study, which was commissioned in 2014 by the General Assembly, makes clear that significant funding increases will be needed to support the needs of this community going forward. And I can tell you personally that I am having trouble with staff recruitment. I have been trying to get somebody in a position for personal supports for well over a year now. I have only one staff person, and that means that when that person is out sick, I have to find other way, or for any other reason, I have to find other ways to make up the shortfall. The reality is people who self-direct and provider agencies, we are facing a crisis because of the continued ravages of the COVID pandemic, which is still with us, the rising cost of inflation, and just the fact that our potential DSPs are going to other jobs which can offer them more for less risk. We are talking about specialized people who do everything from helping people maintain employment supports to activities of daily living. This is a professional workforce, and it deserves to be treated as such. To that end, I would ask you most respectfully to fully fund the Developmental Disabilities Administration budget and support the philosophy which we talked about on Developmental Disabilities Day, which is community for all. That means more people with disabilities in the community, having jobs, doing the things that our peers without disabilities take for granted. But in order to do that, we need your support, and we need it now. Thank you very much.
Thank you. Next, we will call on Daria Cervantes from the ARC of Montgomery County.
Good afternoon, everyone, and thank you so much for the opportunity to speak with you today. I'm Daria Cervantes, the CEO for the ARC Montgomery County. The ARC supports the 4% increase for DDA funded services, but it's not nearly enough as we continue to recover from the pandemic. That's why we're urging the governor and the General Assembly to support a supplemental budget of $35 million in general funds for DD supports. The ARC supports over 300 people with intellectual disabilities. Direct support professionals, or DSPs, perform the most critical work within our organization. The DSP workforce was in crisis prior to the pandemic, but the pandemic has exacerbated this to a point where I couldn't have imagined just 2 years ago. Our current vacancy rate is nearly 32%, with 84 vacancies in our residential program alone. We had job fairs in October, November, and December, and fewer than 10 potential employees showed up for those job fairs in total, and only one was hired. We have a turnover rate of 26%, and each month more employees separate from the organization than are onboarded. These vacancies impact our ability to provide supports to people who are currently in our programs. Sometimes we simply don't have enough DSPs to support everyone, and then we're forced to prioritize our 35 homes and people who live on their own for whom we're their only support system. This disruption to people's lives is not something they should have to experience, but it's unavoidable with our current workforce crisis. Expanding our supports to new people is out of the question right now. This leaves transitioning youth without support to transition into adult life, and we're unable to support efforts to decrease the waiting list. To compound this unprecedented workforce crisis, the rise in inflation is adding additional costs to our operations. Now, all businesses face these same increased expenses, but we can't change our prices to offset them the way other businesses can. DDA-funded providers can't compete with other businesses that offer their frontline workers increased wages, big sign-on bonuses, and perks like shortened work weeks and college tuition. McDonald's, Target, and other similar establishments are now our competition for employees. DSPs perform critical support to Maryland's most vulnerable citizens, and they deserve a living wage that can only be accomplished with increased DDA funding. Thank you so much.
Thank you. And now we'll move to Megan Rusciano from Disability Rights Maryland.
Good afternoon, Chairman, Vice Chair, and honorable members of the subcommittee. I'm Megan Rusciano. I'm a managing attorney with Disability Rights Maryland. We support the governor's budget for DDA and echo the concerns my colleagues Laura, Matt, and Daria have shared. This year's budget provides critical funding for transitioning youth, for over 300 people on the wait list. For these folks, DDA services are a critical lifeline that enable them to live and flourish in the community. This year's budget also provides a rate increase, which has been discussed, for DDA providers, and it comes amidst an unparalleled workforce shortage that's been described in others' testimony. Direct support staff have been on the front lines during the pandemic. They've literally put their lives at risk to provide support to people with IDD so that they can remain in the community and not be institutionalized. Without them, we at DRM have seen firsthand that people with disabilities have ended up in institutions, have been involved in the criminal justice system, have had extremely long stays in emergency rooms. Their importance cannot be overstated. And as part of the DD Coalition, DRM is incredibly grateful to the Department of Health, the Department of Disabilities, under the leadership of Secretary Schrader and Secretary Beatty, respectively, who have worked tirelessly with our coalition to develop a plan to modernize and increase rates for direct support staff. And while we applaud this commitment and the rate increase, additional funding is needed now to address the unprecedented workforce shortage. The rate increase, the glide path that you've heard about, needs to be fully funded now. People with disabilities' lives may depend on it. The budget also falls short in failing to fund the 3,600 people on the waiting list. And for these people, access to services can completely change the course of their lives and embolden their success. We've seen it firsthand. And while we wholly support DDA's budget, highlight just 3 trends in DDA services that need attention and leadership. The first is the need to fund residential services for children with IDD, who without these services are often forced into the foster care system. The second is, as mentioned, the need to fix that definition of personal supports to ensure that people can receive overnight supports. And the third is the need to address the fact that skilled nursing services have been excluded from DDA waivers, forcing many young people with IDD into nursing facilities when they should have access to these services in the community. So we will continue to work with the DDA and the department to address these critical issues, and we urge you to support and shape the budget and the system so that people with IDD can be fully integrated into our communities. Thank you.
Thank you. Thank you for all that testimony. Are there any questions for any of the members of the panel? Seeing none. Oh, Delegate Valentino Smith.
Didn't want to let you down there. So, so thank you, Matt, for coming and really helping to bring us the personal perspective that you bring. So for any of you, Laura or Daria, Megan or Matt, the question I have is, look, I'm just disappointed, shocked, frustrated, because we thought when we got the 4%, we were doing so well, and it took so long to get, and now we're hearing that it is woefully inadequate and that it is continuing to leave this population very vulnerable to not having the essential care they need, or to entering nursing homes, which I think in the analyst report costs like 4 or 5 times more than if we had them we had this type of care being offered in the community. So you said that you need an immediate supplemental budget to come down. So have you talked to Secretary Schrader? Secretary Schrader's heard the testimony. I mean, it is or it isn't a real definite problem in the community. And are you getting anywhere? Or is the department believing and understanding that this is a real serious situation, or are you getting pushback?
Thank you, Delegate. That might be a question for Secretary Schrader. I will personally say, I think you heard it from everybody in the coalition. The department and with Secretary Schrader's leadership has been really incredible, and I believe he is deeply committed to our issues. You know, we obviously don't know what the position of the administration is on the request for a supplemental. And just the one thing I will say is, you know, I think it's a hard message for folks to hear that the 4% hasn't been enough. But, you know, when we had those discussions in 2019, we knew, and Delegate Resnick can probably attest to this, we knew it wasn't going to be enough. We knew we really needed to be around 5 or 6%. And we just couldn't get there. 4% was where we got. So we knew we were going to lose ground. And then when you add the pandemic and inflation, it's just been a perfect storm.
Thank you. And Secretary Schrader's still on, and you know, it's been really encouraging to hear the providers be so thankful for the weekly meetings or monthly meetings and everything that you're doing to help make sure that there's good communication. So I guess Secretary Schrader, given the testimony that we heard, a lot sits in your hands now with respect to the governor and the release of some additional funding. So thank you, Mr. Chair.
Thank you. Any additional questions? All right, seeing none, thank you all very much. T-minus 2 more to go. Mr. Secretary, I think we'll see you tomorrow and on Monday. And then we will move to decisions after that. So thank you all very much. I do want to ask the members of the subcommittee to stick around. We do have a vote session to following this budget hearing on 2 bills. And so once everyone is, once we're adjourned with that, we'll move to that next step. So thank you all very much, and would ask everyone to drop off the line. You all, obviously everyone is welcome to continue watching through the YouTube channel. All right. Okay, now that we are at the committee, subcommittee, let's go ahead and begin. Like I said, we have 2 bills on the agenda. We'll start with Delegate Valentino Smith's bill. What is it's HB, June, help me out.
456.
Oh, you know what? I have them written down right here. Silly me. Okay. We have HB 456. This is a bill that would escalate the minimum senior SNAP benefit. Currently, it is at $30. Again, that is a minimum senior SNAP benefit. That is not the benefit that many or most seniors get who are on SNAP. Many get much more, but this is the floor. The initial bill came in to increase that to $45 per month and to lower the eligibility age to 60. We are there's an amendment that you all should have received that leaves the age at 62 and increases it to 40 rather than 45. What this does is, if you all have looked in the current budget, the governor did fund $5 million in the current budget to raise that minimum from $30 to $40. It is DBM's intent to continue that, but because they have not put in legislation, we have to rely on the governor next year, whomever he or she may be, to continue to do that. So by passing this bill in line with what the governor did in the budget this year, not only are we raising the amount that the seniors on SNAP will get by $10 a month, but we are also codifying the governor's intent that this minimum continue at this rate. So that is the amendment and the bill. We can go ahead and take this informally. If anyone wants to comment or question or et cetera, we can do that before we make any motions. So does anyone want to follow up or have a comment or a question?
Yeah, thank you. Sure. What was the total amount you said? I'm sorry.
The governor budgeted $5 million for the year
Carrie.
to raise it from $30 to $40 million for $30 to $40 per month.
So then the $5 million, what the bill would do is make it for the next year, and how many more? I'm sorry.
It would be permanent, and it would be the same $5 million a month. It would be exactly the same as what the governor did this year. It would just carry on moving forward permanently.
Okay, thank you.
Right, and what that would do is, if there are seniors who are getting the minimum SNAP benefit this year, they would get an extra $40 a month. They would get an extra $10 a month. We don't want to take that away from them once the budget year is over. Remember, seniors are on limited income. Many don't work. Many have disabilities and are aging. So these are not folks that can get off of SNAP if they are in the poor senior age. So.
And I appreciate, and I certainly don't want to sound heartless, but in essence it is, and it would be, I guess, permanently establishing this
correct
entitlement one way or the other. Okay,
correct.
Thank you. Appreciate explaining it.
Delegate Henson.
If my memory's correct, I remember some very compelling testimony from seniors that were impacted by this, and them stating that this would be just a small step in the right direction, and really the need that exists is even greater. So if my memory serves me correct, it sounds like it's certainly something that there's a huge desire for. So I thank the sponsor for bringing the bill.
Yep, absolutely. Delegate Valentino Smith.
Thank you, and thank you, Delegate Henson. I mean, clearly it's a compromise to what was put in with respect to lowering the age and the amount, but Delegate Mangione, just for purposes, the department DBM put testimony in the file that it was the governor's intent to fund the $40 in the budget that was sent down, and that it's the department's intent to fund the $40 minimum monthly amount in subsequent years, and it has been built into the budget forecasts. So in my discussion with the department, they did intend to do the $40, the increase from 30 to 40 in this budget and in the future budgets. But because there's no BRFA where they would do the statutory change to go along with the budget, we've got to do the statutory change in the bill that I put in order to assure whoever the next governor is that they fulfill the intent of Governor Hogan, which was in future years to build it into the forecasts.
Thank you for explaining that.
And to be fair, it would have been appropriate if the governor had put in a bill, an administration bill, to do this and make it permanent. But from my perspective, I'm perfectly happy to give the credit to Delegate Valentino Smith. So with that, I'd like to entertain a motion for the amendment. Geraldine, do you want to do that?
So I saw Delegate Henson beat me to that.
That's fine.
I would move the bill as amended.
All right, well, let's do this right. Let's.
All right, the
Delegate
amendment.
Henson, you move the amendment. Do we have a second?
Second.
All right, motion and a second. All in favor signify by saying aye.
Aye.
Any opposed? All right, now Delegate Valentino Smith, please have the honors.
Move the bill as amended.
All right, is there a second? All right, there's a motion and a second. Delegate Henson, I'm not hearing you. I see your lips move, but for some reason I'm not hearing you, but you're not on mute. I don't understand. But I did see it, so we can count. There's a motion and a second on the bill as amended. All in favor signify by saying aye.
Aye.
Any opposed, raise your hand.
I think I'm going to be opposed.
Okay.
For now, at least. For now. I think that, believe it or not, some of the others were just, as long as I understood it correctly, so I'm not against this being funded, but I just, of a mandatory never end date of a program is where I have the opposition, but I'm glad to see.
Fair enough. And just so that you are aware, this program is already a mandatory never end date. It's just we're raising by $10 the amount that they would receive, the minimum that they would potentially receive. All right.
I would remind you, Delegate Mangione, that you have a genetic predisposition to feed people as an Italian or fellow Italian.
All right. Okay, then. With that, the bill passes subcommittee. It will be on the vote list on, I believe, on Friday. We have one more bill, HB 81086. This is one of two bills that Delegate Rosenberg has submitted for the opioid restitution fund. This is not the bill we heard yesterday. This is the bill that establishes the task force commission. We will take that up at a later date. This is a bill that does some minor tweaks to legislation we passed, I believe, 2-3 years ago, or 2-3 sessions ago, that established the opioid restitution fund. I believe this bill will simply allow for whatever, to accept whatever settlements come our way to be distributed and used through the intent of the bill. So with that, there are no amendments. Is there a motion? Well, why don't we just do motion and then we'll do, let's follow Mason's rules for once.
Sorry. That's why you're the chair.
Okay. Is there a motion?
Move the bill.
Is there a second? All right. We have a motion from Delegate Valentino Smith, a second from Delegate Mangione. All right, discussion. Delegate Valentino Smith.
So I'm sorry, I just had a question, June. So this is going to allow the funds to go to the jurisdictions that agree to be part of the settlement. So Baltimore City didn't agree to be part of the settlement. So are they still going to be available for distribution of the funds through this bill?
So my understanding, they would have to do it separately on their own. So what this does is it channels the funds received through the settlement, and it has to actually just meet the state agreement. So that's what this do. Yep.
All right. So Baltimore City still has to kind of, and any other jurisdiction that didn't sign
right
on has to go it their own way and not get the distribution of funds through this.
Right.
Thank you.
And also keep in mind, in addition to whatever settlements they do, there are additional lawsuits that the state is a part of with other pharmaceutical companies that is still not settled, that we as a state have not agreed to yet. So there is potentially more money or potentially no more money. It just depends on what the next year or a couple years with hold for us. Okay.
Yes.
And the decisions of whomever the next attorney general is as to how to pursue these matters. So, all right. Any other questions? Okay, seeing none, we have a motion and a second. All in favor signify by saying aye. Any opposed? Raise your hand. All right, no opposition. Thank you all very much. Bill passes. It will also be on the voting list for Friday for full committee. We will have another voting session, I believe, on Monday. So tomorrow we have a budget hearing for, what's tomorrow, June?
I believe it's family investment.
No, we already did family investment.
Very good.
Wait, I'm sorry, Social Services
So
Administration.
SSA, right? Okay, so
Yes.
tomorrow's SSA, and then Monday we will have Medicaid, and then another voting session for the next set of bills. We don't have a lot of bills going through our subcommittee, as most
Yet.
noticed.
Yeah.
Well, not really.
I still have some.
You may still have a couple, but I mean, in proportion, you know, the education subcommittee has an overwhelming majority of the bills that come through our appropriations committee. So we don't have a lot hanging out there, but you know, we deal with it as it comes along. Okay.
Also, Mr. Chairman, I
Yeah.
also remind the subcommittee that we start at 2 p.m. tomorrow because of the time conflicts we have. And
Sorry,
then-
I'm getting called to HDO. Sorry.
Okay.
Not a problem.
And then just a reminder, OLA also is presenting on their audit of Social Services Administration after the budget hearing.
Great.
Okay.
All right. Awesome. Thank you so much. Thank you, everybody. We are adjourned.